Okay, so in this video, I'm going to talk about the case approach for assessing the suicidal patient. So the case approach was actually designed by Dr. Sean Shea, and it was published in his book, The Practical Art of Suicide Assessment. So I recommend that book to anybody who's interested in learning more about assessing suicidal patients or who intends on working in an emergency setting where the assessment of a suicidal patient is crucial to your success. So CASE stands for Chronological Assessment of Suicidal Events. It helps you to ask about everything relevant to the patient's suicide risk. The basic approach starts as such. There's kind of 4 parts to it. You start by assessing the presenting SI or event, so figure out what happened. That's a classic question you're going to ask any patient who walks into an emergency department or any psychiatric evaluation. You're going to say, tell me a little bit about what brought you to the hospital. Give me an idea, tell me a story about what happened, etc. Elicit information about any SI over the past 2 months. So say in the previous 2 months, how many times have you thought about suicide? What kind of thoughts have you had? What kind of plans have you had? How far have you gotten with the plans, etc. Explore any past SI, because again, previous behavior is a good predictor of future behavior. So we want to look at any past suicidal ideation or attempts, and then return to the present to explore the immediate suicidality. And this approach allows you to explore the presenting and past events while also, most importantly, building rapport with the patient, because you need this patient to trust you and to believe the things that you're saying is going to help him or her. So build rapport with your patient. So how do we go about asking the questions to a potentially suicidal patient? This is a big deal because it might be difficult. You might think, how do I do it? One way is you can just do a direct approach. You can say, as part of CIGI-CAPS, have you felt suicidal? Or have you had any thoughts to hurt yourself? That's a reasonable way of doing it. Another more smooth approach that you can use is you can say something along the lines of, sometimes when people feel depressed, they have thoughts about ending their lives. Have you ever experienced any thoughts like this? So you can say, and you can kind of apply that to anything. Sometimes when people are really upset, they have thoughts of ending their own lives. Sometimes when they have a lot of stress in their lives, they think about ending their life, etc. So you can kind of tailor that however you want, but basically the smooth approach is sometimes when people feel depressed, they have thoughts about ending their own lives. Have you ever had any of those thoughts? That's a good way of kind of discussing it. And then you might also say something like, considering all the stress in your life, did you ever feel like it would be better to not wake up tomorrow? And that's kind of assessing for more of the passive suicidal ideation, right? Passive meaning, I'm not trying to actively kill myself, but if I died tomorrow, I wouldn't really care. That's more of a passive thought. These questions kind of normalize the feeling for the patient. They make them feel like, having suicidal ideation is common, other people have it, I'm not the only one. It kind of allows them to feel more comfortable. And basically, you can also say, if they say yes, then you can elaborate. You can obviously follow up. So if you ask the person, you get a positive response for any kind of suicidal ideation, you can ask follow-up questions like, have you had a specific plan? What are some of the ways in which you've thought about ending your life? So again, kind of leave it with more open-ended questions. I think anytime you're dealing with depressed patient, suicidal patient, it's best to work with open-ended questions because it gives them a chance to kind of discuss it from their own perspective. And you're going to get a lot more information that way. Most patients with moderate depression have had some kind of passive suicidal thoughts. If it's never gone beyond that point, you can rest a little easier. So the point being there is, again, if the thoughts are only passive suicidal ideation, like, I wish I wasn't alive, I wish I wouldn't wake up tomorrow, that's a little less concerning. It's still concerning, but not at the level of someone who's actually having active thoughts. If there's active SI, you have to ask more questions. You have to first figure out how realistic is this plan that this person has. If they thought about cutting themselves, do they have the knife? If they thought about taking an overdose, do they have all the pills? If they thought about jumping from a window, how high is the window? If they thought about shooting themselves, do they own a gun? If they thought about hanging themselves, have they made a noose? Those are all kind of questions that you want to figure out. And again, asking about those particular means, like even if you were to go through every single one of them, have you ever thought about cutting yourself? Have you ever thought about taking an overdose? Have you ever thought about jumping from a window, shooting yourself, hanging yourself, etc.? Doesn't necessarily mean that this is going to give the patient thoughts and then they're going to go home and do it. It actually, again, is reassuring to them, it helps them feel comfortable discussing these things with you as the clinician. You may feel like this is putting ideas in their head, like I said, but actually, it helps them be truthful, honest. It's a very good point. Now ask, how close have you actually come to harming yourself? So have you planned it in your mind? Have you wrote it down? Have you Googled different ways to die? And have you gathered any of the items needed to complete the act? So again, this is assessing like how far they've gotten with the plan. So have they simply just planned and plotted it out, wrote it down on a piece of paper, or looked at it on the internet? Or have they actually gathered up all the items? Like I said, have they bought a gun, made a noose? Have they gotten all their pills and medications together, etc.? Now you want to figure out how close they came to completing. So the example I'll use here is the overdose example. So have you ever had the pills in your hand and a glass of water ready? Have you ever put the pills in your mouth? Have you ever swallowed the pills? And this can be applied to any specific method. Other things to ask about is, has the patient wrote a suicide note, or have they put their affairs in order? This is also very important because, again, this kind of assesses, I think, the seriousness of the situation. You'll be much more concerned with somebody who's actually wrote a suicide note, or somebody who's put their affairs in order, like got their finances in order for their family, etc. This is much more cause for concern. And again, going back to the other part of this slide where I said, figuring out how close they came to completing, you can do that for anything. Like you could do that for, say, gunshot, right? Or think of it, someone says, I thought about shooting myself. Okay, well, do you have the gun, number one? Have you ever put the gun on the table? Have you ever held the gun in your hand? Have you ever put the gun in your mouth? Etc. And this can be, again, applied to any one of those methods. Now you want to ask about the immediacy of the intention to determine the need for hospitalization. So the whole point of this, and again, I think this is someone you're going to probably see in an emergency setting or on a consult service, say, you're going to need to assess, does this person actually need to go to the hospital? Because if they do, you need to figure out the disposition. So ultimately, a lot of emergency psychiatry or emergency medicine in general is simply disposition. You want to figure out what is the best place for this person to be. So with that said, you want to ask them, are you feeling suicidal right now? Do you have any specific plan to hurt yourself? And this is probably one of the most important things you could also ask is, what's prevented you from completing? So you've been thinking about suicide for the past 2 months. You had a plan. You had the means to do so. What stopped you? I just want to ask, what stopped you? That's a good way to kind of approach this with a patient. Figure out what stopped them. And again, I really feel like with a lot of these people, it's going to be children. So many depressed patients will be opposed to suicide because of children or religious beliefs. Now, the religious beliefs one is a difficult one to deal with because a lot of people say, oh yes, I'm Catholic, I'm Christian, but I haven't been to church in 20 years. Well, that doesn't really count, right? Religion, doesn't necessarily be that protective there. You really want someone who's actively religious, attending church on a regular weekly basis, who's actively involved with other members of the church. Those things would be very protective. But just religious beliefs alone, like, say that if you commit suicide, you go to hell, but I don't really practice any kind of religion, that may not be that protective. I'm going to save this slide for the next video, but contracting for safety, I kind of spoke about my thoughts on it before, but I'll give you guys a better idea of what contracting for safety should look like.